As one tale begins, another one ends, Jackie Chan once said. But it's not as simple for everyone. With the rise of diseases such as cancer and dementia, palliative care is becoming increasingly important. In the Netherlands, palliative care is divided into 4 phases. The first phase focuses on disease-oriented palliation, whereas the final phase is more focused on aftercare for the relatives of the patient. In Zambia, palliative care is also becoming more important, with 6 organizations that offer this type of care. Zambia is a WHO-classified lower-income country. 54% of the population lives on less than $1.90 a day, and the average life expectancy is 63 years. Besides tropical diseases, cancer also accounts for an increasing share in the number of deaths. This rise has a huge impact on the healthcare staff. But what does it really look like over there? That is what we're going to try to find out. In this documentary, we will take you to Macha Mission Hospital. This is a rural hospital in the southern province of Zambia.
My name's Clever Musaga. Yeah, I'm a chaplain helper. Yeah, we are 4 here. God is the only healer. It's the only deliverer. There are some people who come to hospital for treatment, but some are witched. Some are demonic. Yeah, but God is there to deliver and to heal them. As Christians, we do believe that nothing is impossible to God. So sometimes when we are preaching there, if someone is sick, is under attack with a demon, yeah, the demon manifests. Yeah, then we pray for that person. He delivered, the sickness gone without treatment. So sometimes some people, they are in bondage. That's why that's the main aim of being here, to deliver people, heal people, encourage people. On Wednesday, every Wednesday, 14 hours to 15 hours, we do have chapel program here, chapel service. Patients, those who can manage to come out of the ward, they do come here, we gather together, preach the word, sing. Someone will go around in the ward, all the wards, male, female, peds, maternity, gyne. Yes. Preach the word, praying for people, counseling for patients. Yeah. Sometimes the doctor failed to treat that person. Yeah. And they hand that person to us as chaplains. Yeah. By the grace of God, we pray, people healed. The patient themselves, sometimes they do say, take me to the pastor, take me to the chaplain. I want to be prayed for. Call me the pastor, call me the chaplain. I want to be prayed for. Yeah, they believe that God can heal them through the pastor. When the chaplain pray for, they do believe that healing is taking place. For example, some people, they'll be in the ward, they can't walk. Treatment day and day, the nurses, the doctors give them treatment, but nothing's going on. No change, in short. Yeah. Some people, they do push them, bringing them here in the office. Yeah. After praying for that person, he or she can walk on his own, going in the ward. They discharge that person. So, in short, things are happening. God is working. yeah, in our mission, Macha Hospital. Yeah. There are many people who come here. The doctors, the nurses fail to treat them. But when we go and pray on the bed, or they brought that person, prayed for, things are happening. Yeah.
I'm Blessed Mtoiwa. I'm a registered mental health nurse. Well, currently, I think yes, I have. Yes, we have a patient. I'm enjoying doing it, like seeing the patient who is in pain. You are doing everything you can so that at least the pain is lessened. It's kind of a good thing for me to do it. Yes, we give yes drugs, especially analgesics, and also to the patient and the relatives. We do sort of counseling. Yes, we counsel the patient so that you go along in the line of treatment, so they know how you are managing the patient. It's also helpful in terms of cooperating with the patient and the relatives also, because they know what you're doing and they know how things are going on a daily basis.
Here, no, because since we don't do it the way it's supposed to be done. Since it's being done home, so I think I can suggest that maybe if we can have a word specifically for them, maybe it can be good for us. Otherwise, we don't have. We just send them home. If the doctor recommend them for palliative care, they just told them to go home since they can't manage with the treatment. So they just sent them home with the drug with instruction, including counseling, so that but we don't have follow-ups because they stay from distant places.
I'm not happy because there are few people who are trained in intensive care units, like here in Macha. And then also the infrastructures. We don't have space for people for those people with the life threatening conditions we can place them into. So for that is the reason we send them home, so that we avoid nosocomial infections to them. So we send them home to decongest the hospital, so that we also prevent them from other conditions. But otherwise, I'm not happy what is happening currently.
Even the family are included. It depends, but some they are happy, some they are not. We even include the spiritual support, even what's going to happen to them. If it's how to feed them, we also encourage them we teach them how to feed them, how to bath them, especially if they are unconscious.
Like, let's say conditions like schizophrenia, we usually, after counseling, when they go home under palliative care, we usually involve them in other people, in groups, in therapies, like those people who experienced the condition before and how they handled it. So because people are depressed, knowing that it's a life condition, they have to live with that condition for a long period of time until maybe they die. So what's happening, they continue on the treatment counseling. When they go home, they mix with other people, since it's hard for us to follow up. So we link with them, with those people who already experienced that condition, and how they managed to do it so that they don't fall into depression. We're hoping the best to our patients. So definitely, if there are well wishers who can help us who in terms of human resource infrastructures, we can really be happy, because it will be done excellently than what is happening now. For now, where palliative care is concerned, we're doing it, but it's was still it's not yet good. So if we are assisted with infrastructures and people who are specialized in those areas, we can really appreciate, because the work can be done better.
This one is in there, but this one.
Morning, I'm Dr. Mulangi John. I've been working at Macha Mission since 2011, so this is almost 11 years now. Palliative care, actually, it's organized just the way it's organized in Zambia. At the national level in Lusaka, we have a palliative national team, which is also represented in the province and the district, even in hospitals. So at Macha, we have actually a committee, palliative committee, but which is not active. Why is it not active? Because most of the things which are required for the team to be really active they were not provided. We used to provide palliative care for all RVD patient or patient who presented with cancer and they were not supposed to send the hospital. We send them home for home-based care, and our palliative care team should visit them once in a while or twice a week. So lack of transport, lack of money, lack of drugs which are needed, so all those are making the team not to be really very, very active on the ground. Usually when we go out, it's just for painkillers, some hematinics, just to boost the HB. But palliative care, when we realize that the HB is too low, we bring them back here. So for them to receive blood, they receive from the hospital, and other strong drugs need to be given in the hospital. There are a lot who are supposed to receive palliative care, but unfortunately, they are not receiving it. We really don't tell patients because we don't want them to lose, to be desperate. So what we discuss as a medical team, we know that we are missing this one, but instead of giving a strong, imagine somebody with cancer which is already advanced, they're in pain, they're not sleeping, actually they die because of that. So lack of strong painkillers, so we are giving them Panadol, the only drug we have here, or diclofenac, but which is not really indicated in that situation. We really don't tell the patient that because in our area here, it depends on the level of education of the patient. So at first, you try to discuss the patient. If you realize that your patient is not cooperative, because we have lost 2 patients here because clinicians, they told them about the situation, then they just went home, they took some stuff, they died. Actually, for us to make sure that this case need palliative care, we call family members, we discuss with them, we tell them that this disease cannot be curable. So the only things we can do is just palliative care. So whatever symptom the patient can present, we just deal with that one, but to try to extend a bit their lifespan. So our patient, the level of education and understanding is a bit difficult. So what we try to do is to involve the family members, the mother, or the father, or another family member who can understand this, who can give them that support at home. Probably slowly, when we work on the patient, we can tell them. Especially if we send for home-based care, we always involve 1 or 2 family members who are a bit educated, who understand the disease. We tell them what they should do, and we tell them when they should bring the patient for review to the hospital. We discuss with them, yes. Lack of medicine which are really needed, especially in terms of cancer or which patient need the strong painkillers. Because my experience here, I've seen most of the patients are coming, they are dying because of pain. When cancer is advanced, they are really in pain. They are waking up in the morning in pain. They sleep in pain. They don't eat because of pain. So lack of painkiller, they are dying faster than they should. I think 2 weeks ago, we had a patient in a guy ward. She came with advanced cervical cancer. We had sent her to UTH for chemotherapy, radiotherapy, but unfortunately, she couldn't afford to pay that. So she came back already sick, anemic, weak, and everything. So what we did here, we just gave some blood. We put NG tube for feeding. She's now bedridden. She can't walk anymore. So she stayed with us here for about 2 weeks. Then we discharged her home. So we told them to say they need to be bringing her probably after 2 weeks. But normally our team was supposed to go and see how she's faring at home, but which we can't do. What I would want to see differently is the team need to be reactivated, and a lot of people need to be trained in palliative care. Palliative care is also a discipline under medicine nowadays. Most of the people are not trained, so all of us, we need to be trained so that we provide good palliative care to patients. Yeah, my hope is, you see, Macha now is becoming big, and palliative care, we are having a huge number of patients who are in need of palliative care. But unfortunately, we have little people who have that knowledge on palliative care. So my hope is, or my core right now is, if we have any partners who can try to help us, or to the government, to train more people, because all the health professionals nowadays, they need to be trained in palliative care so that we provide good palliative care to our patients.
Palliative care in Zambia, a new branch in healthcare that is still under development. The healthcare staff are trying their best, but they acknowledge that still a lot has to be done. With a clear message from Dr. Mulangi. Improvements in policy, drug distribution and service expansion are needed to ensure high quality palliative care throughout the whole of Zambia.